First of all, I have some conflicts of interest, of course, and especially Vygon, of course. As you know, as we know, unfortunately, the prognosis of cardiac arrest is very low. About 10% of survival rates all over the world, and specifically in this study in Europe. The problem is that I'm part of people who are working on the guidelines in the ERC and HA, and we know that when focusing on chest compression, on hemodynamics, and the new guidelines are the same, importance of hemodynamics, importance of early defibrillation. But what about ventilation? Did you have time to read a little bit the more than 100 pages of these new recommendations? There is nothing very new in terms of ventilation in BLS and in ACLS. Perhaps because there is nothing to do. There is no need for ventilation. No need because, as we can see for a long time, we know that when you compress the chest, you ventilate a bit the patient as well. And here in pigs, 20 years ago, Pierre Carli showed that with only chest compression, you can ventilate patients 6 liters per minute, or not patient, but pigs. The same when the patient or the pig is under ventilation with a ventilator. You increase the influence of ventilation while doing nothing with ventilator and then compress the chest, and so you increase the flow of air. There is no need, and here it's not big, but it's human. And in human beings also can see that there is here, just here, standard CPR, an increase in mid ventilation, just with chest compression. So there is perhaps no need to ventilate. And there is no need because the first 5 minutes, as you know, there is no decrease in SaO2. So the oxygenation is quite good. It's only pigs, but also in humans. So this is first the orders for the resident in anesthesia, showing that, there is no need to ventilate. Look at this guy and this girl, sort of handbag. There is nothing to do. So it's the order, nothing with ventilation. It's not a mistake. It's the order. But when you have some causes like asthma, like hypoxemia, pneumonia, etc., what can we do? We perhaps have to ventilate a bit. And the recommendations are saying that as well. First, okay, only chest compressions, okay, but after that, if there is some hypoxemia, then ventilate a bit. And there is synchronization between ventilation and chest compressions, 32. It's the same this year as well. And when we professional, physician, etc., doing this, we have first, during BLS, to synchronize ventilation to compression, but after that, have asynchronous ventilation with low rates of ventilation. We have side effects. It's the reason why perhaps ventilation is not so good. Why? Because there is gastric inflation. Gastric inflation means regurgitation, aspiration, pneumonia, means also the decrease in the course of the diaphragm, ascent of the diaphragm. So there is a decrease in pulmonary compliance, not good for coronary perfusion pressure. What about cardiac output? We know that cardiac output induced by chest compression is very low, 20% normal. But if you have a very low cardiac output, there is no need to ventilate a lot the patient in order to maintain the optimal ventilation to perfusion ratio. And when you ventilate, basic life support, you also decrease CPR fraction. So meaning that the percentage of chest compressions is lower, so not good. So if you ventilate the stomach. And it's true, in real studies, like that one, we performed this year, showing that only T0 and T6, you have a huge amount of air coming to the stomach while performing ventilation with the back valve mask, or before intubation. We know also that if we ventilate the patient, it's not good for coronary perfusion pressure. Here you can see that there is the compressions here the aorta, here the right atrium, and the difference during decompression is coronary perfusion pressure. So you increase this, but at the end, while ventilating the patient, you decrease rapidly the coronary perfusion pressure, only with 2 insufflations. So that's not good at all. And coming back to the optimal level of coronary perfusion pressure means that you have to compress the chest again at least 20 times. There's also a problem of heart-lung interaction. Ventilate the patient is not only oxygenation, ventilation, it's also hemodynamics because of the heart-lung interaction. For instance, while the patient is intubated, if you decompress the chest, then you'll decrease the intrathoracic pressure. Decreasing the intrathoracic pressure means that you decrease the right atrium pressure. Then you increase the coronary perfusion pressure. That's good. But if you decompress the chest and you have an insufflation with that time, then you will increase the intrathoracic pressure and then you will decrease the coronary perfusion pressure. And we are doing that every day with our ventilators. But when you compress the chest and then there is an insufflation, then you increase the pressure. And if you increase the pressure, you increase the stroke volume. That's good. So what can we do for that? What can we do? First of all, can we monitor the quality of ventilation as we are trying to monitor the quality of chest compression? It's difficult, and the new recommendation this year are saying that, okay, as usual, try to do something. Just gently ventilate the patient if it is possible. I don't know how it is possible in the real life. But you have to push rapidly some gas and some oxygen in 1 second. Insufflation. So rapidly but smooth. So stop it with the aggressive ventilation and then just smooth ventilation. Smooth ventilation means that with only 4 fingers you can ventilate the patient. It's the Bobro technique or princess technique or the tea time technique. It's my name. We can also, you can decrease, please. Thank you. Just decrease. Totally. Okay. You can also try to give chest compressions, but also insufflate the patient, but without stopping the compressions, And every 10 compression, you try to ventilate and insufflate the patient without stopping during BLS. It's also possible. It's also a new technique which is studied for the moment by Daniel Davis from San Diego. How can we optimize? Perhaps synchronization could be good. So during CPR, if it is possible to synchronize ventilation and compression, this could be something very interesting. Because they are saying that during CPR in intubated patients, you can only give sometimes not more than 40 milliliters of gas. because of this interaction. That's not good. So decompression during insufflation or compression during insufflation with this kind of ventilator, for instance, can be something also interesting. And in this study, they wanted to know whether the synchronization can be good in terms of hemodynamic ventilation and so on. So they tried to ventilate the patient. Here you can see the pressure, the intra-aortic pressure, and here the time. Okay? During compression, you insufflate, and during decompression, nothing. And what about the results? You can see that compared to IPPV, what we are doing every day, you increase the level of PaO2. So that can be good. And you also increase the level of pressure. So that can also be good as compared to IPPV. But you can do nothing. Nothing, meaning not nothing, but just oxygen. Flow of oxygen. These studies are all one, but we have plenty other studies after showing the same results, showing that as compared to control in red, when you only give oxygen and no insufflation while compressing the chest, you have a good PaO2. PaO2 is still the same, even though it's decreasing a bit. And you'll have a PCO2, which is, of course, a little bit coming up. But it's not a problem, really. The problem is the coronary perfusion pressure. And here it's exactly the same. So giving only oxygen can be something interesting and good. Regarding humans, in humans we can also do that. Insufflate a little bit gently and continuously the patient. And in this other study, Ben Bobrow is also a friend, showed that regarding the outcome, which is CPC1 survivors, you can see that it's greater in this group with passive oxygen than with the black valve mask. So this can be something perhaps interesting, meaning that you always compress the chest and then the coronary perfusion pressure and the brain are well perfused and continuously. So this is something, it could be something very interesting to do. So in conclusion, ventilation during CPR is not optimal. Synchronization can be good. During BLS, no. No, why? Because when you synchronize, you stop the chest compression, and so you increase your no flow duration. Second, asynchrony. During ALS, is it good? No, because asynchrony decreases your coronary perfusion pressure. So what we need? We need no side effect, of course. No gastric inflation, no aspiration, no atelectasis, with only oxygen. We need good oxygenation, of course. We need the washout of CO2. No heart-lung negative interaction as well. So we have to improve hemodynamics, okay, but also ventilation. With new techniques, perhaps. Thank you.
So, I'm very glad to be here, and I wish you a good morning again. I wouldn't be here if I don't have a whole support team of emergency physicians and emergency nurses, of course. And together, it's now for 10 years that we use the combination of the Lucas, now it's Lucas 2 of course, and the endotracheal tube, Boussignac. So there's a bit of, perhaps, that you are thinking, well, what is he telling here? But it is the Boussignac endotracheal tube. So it's not the B card from now, it's the tube. Okay, I've had to stand here because otherwise they won't hear me. Okay, so here we are now, and here is my hospital. 850 kilometers from here. It's not far, only 1 hour by plane. Not much at all, but still, this is my team. We have 5 and with 2 residents. But what did we do? I think the most important thing that we all have to keep in mind is we need to deliver quality resuscitation. Not only quality CPR, but after CPR comes resuscitation. And quality is our main business core, right? So, the ancient concept, I have nothing against the ancient concept, in the contrary, but there are some things, I'm sorry, that you can't imagine how long does this exist. That was my frustration 10 years ago, even now. This is known. We all know this. There is nothing new about it. We had to make CPR, I wouldn't dare to use the name sexy, but it has to be wow, it has to be boom. And with this, really, nobody liked CPR anymore. It was done. So we had to push it new life again. And okay, this you know, this is where CPR stands for. I don't have to explain you to that. Patrick explained to you nicely, great. But the main thing is you get the air in, you get the CO2 out, and remember the heart, you need perfusion, right? That's the thing. So, you remember this? That's one of my, I would say it's behind of my bed. No, I'm just kidding. But still, this is a poster that let me say, well, okay, we don't have much time, so let's use it. Because we never, by Michael, arrive within 10 minutes. Never. So hopefully, there is some bystander CPR going on. Because otherwise, it will be for nothing. So, where happens the cardiac arrest? Sometimes it happens near to you, but mostly it happens far away from us. And then we need to go there. So the problem is, you're not the only one who can save lives. There are other people. So you need to be interested in those people. They are lifesavers. We are not lifesavers. We are just supporting life. But we don't save lives. That's what happens in the first minutes. And we never arrive in the first minutes. You agree? Yeah. I think so. Huh? All right. So, time lapse. Jesus. Survival. Oh. And an outcome. That's what we go for. And we all like big, good outcomes and very small time of intervention, don't we? So, you all know, and he's a famous one, he always comes back, he's my big idol, and he showed us already in 2005, well, there is something else than manual CPR, and it works. The only thing is, you need to get there in time. On a death, where nobody's doing anything, you can't gain any life anymore. But if you are in time, then it is really nice stuff that I'm presenting to you. So, I have another one. Not only compression was possible by mechanical way, but there was a team that said, wow, you don't need ventilation. And Patrick explained why. But we didn't know it at that time. We only thought, we blow and we pump. We blow and we pump. And Jesus, what happened? So, we worked out a concept. And that concept was very broad. Because, like I said to you, it happens outside the hospital. So we needed to get people with us from the fire department, from other ambulances, from other hospitals, to share our idea. Go along with us and we'll see how far we get. All right. And we train everybody, even general practitioners in doing Lucas, because that's the one that they don't know. All the rest they know. And we took 6 months for this. And this is, of course, the mannequin where everything turns on. Remember this, we always put this because you need to save the skin. And although it's more gentle now, the Lucas too, but we always put something beneath it. All right, we go for goal-directed CPR. You agree? That's the thing. So perfusion. Patrick told you about coronary perfusion. Systolic pressure is important, and cerebral perfusive pressure. So you need to have all those three together in order to save your patient, right? That's the goal-directed CPR. What about ventilation then? That famous concept, you only need continuous insufflation of oxygen. What does it do? Well, I'll tell you, if you take a blood gas analysis, you see PO2s around 80, 90, even less a bit, but never less than 70, and PCO2 around 50, 60. Is that a problem? Tell me, do you find that a problem? Who finds that a problem? Raise your hand. Nobody. So, it's just perfect, isn't it? Okay. Right, we go further. Of course, the difficulties. Everybody encounters difficulties in life, isn't it? There are believers and unbelievers, but unfortunately unbelievers are more than believers. But our mainstay was to get the unbelievers believed, or in between. Right? The guidelines, we follow the guidelines. We are never going to do something against the guidelines. So we follow the guidelines and we do what they say to us. And all the rest, we get protocols. But there is a problem, because an EMT can't put a tube between the vocal cords. So what do you need? You need something that is almost efficient, and that afterwards, when you come there with your medical theme, you can put a tube through it. And what is it? We called it the fast track. Very nice. And you could put the Boussignac tube on it, and everybody can take or can make a fast track to put in the patient's mouth, because you don't pass the vocal cords, so there's no legal problem. Right. So we continue. You know the fast track, of course, I think. Yeah. First protocol. Yes. You see here, implementation of Lucas and Boussignac or fast track at this moment. So first we follow the guidelines, and then we do our thing. Secondly, without bystander CPR, we come on scene, and we immediately, after the first intake, like we call it, we put on our device. Okay? And you know what? You're doing something else. You are thinking. And normally you don't think when doing reanimation. You're sweating, you're pumping, you're in a nervous situation. We don't do that anymore. We aren't nervous anymore. We say, yes, we can think now. Okay. And everyone, we like CPR. Everyone is, wow, yes, it's something new, it's technical. It's that what we needed. It reinforces your team because they are with you. All right. So, 2005, spring, we started, and nicely, we went to Lund, we saw 16, and we saw also this. Yes, our nice pics. And those pics still are some of the, let's say, the things that we use to show if CPR is effective or not. I agree. But you're in the out of hospital. You need to get the patient into the hospital. Right. So, is it possible in an ambulance driving 80 kilometers an hour? Is it still sufficient to get good CPR with Lucas? That's the question. Is the CEO tube, the Boussignac tube, efficient for ventilation during transport? Is it? Is it? That's the question. So, you see here, big man, the big Boussignac group, and they studied some nice things, and they showed some nice things. And I'm going to show us to you another nice thing. This is our first case ever. It shows a bit primitive now, don't you find, Frederick? A Lucas 1? The hell, who has a Lucas 1 these days? But still, you see, this is our first patient. He came into hospital with a Lucas on, with a Boussignac tube in it, and we went with him to the cath lab because we saw there was some problem, and we thought, well, yes, we are sure it's his coronaries that are boosted. So Lucas on, tube in, and we went through the corridors of the hospital. Everybody said, oh, what's going on? Jesus Christ, are they completely driven mad? And we came to the cath lab, and the cardiologist said, what do you want to do me here? I don't know what to do. I said, well, no problem. Let's do it. And he showed how to do it, and he had never done it, but he managed to do the PCI procedure. And what did we get? The first nice, safe patient. How glad we are. And you know, this patient, the only thing he remembered is, where are my rabbits? Because the last thing I remembered is I went into my garden to feed my rabbits. Where are the rabbits? But he didn't complain of anything else. It was for us. God was sending some message. Okay, so we started a study to see, can we do better? Can we do good outcomes? And of course, can we get it to everybody? And we went to Ghent, the ERC, and we came with a poster. And you see, you want some figures, right? Okay. The number of patients isn't that big. That was our first study. And in that group, there were non-Boussignac tubes also, but only 10. But let's look at the Boussignac group, Lucas. Look at here, and don't smash at me. A ROSC of 37.5% in this patient group. Even 44 when you only count for Boussignac. 44% of ROSC. We don't talk survival here. Eh? I only speak to ROSC. That means from out of hospital, into the hospital, and then to the cath lab, to the intensive care unit. That's what I mean with ROSC. Of course, if you go to survival rates, it descends, but still, it kept 26%. You know the average rates? Tell me, how much are the average rates? Between 3 and 5. So, I hardly said, well, am I going to show this? Because they're going to smash me with tomatoes, I think. Right. So we presented a second study with the Lucas 2, of course, that's the electric-driven one, and with the Boussignac tube, the one where you can cut the oxygen off. Okay, second study. And there, what did we see? Well, okay, a bit more patients, right? And you see here that the survival rate, the end survival, that means patients discharged from the hospital, was now 15, and the ROSC was 41%. Isn't that amazing? You don't like that? You don't want that in your proper service to show that it works. But still, this is one of the most important things, and don't throw me from this, but everything counts and everything is about time. If you're there in time and people are doing something, not special things, but just doing something, you have a good opportunity to get them out. If they are doing nothing or your intervention time gets along, then your survival rate decreases spectacular. This case I will never forget. I was called at the cath lab because during a procedure, the cardiologist injected intracoronary adrenaline. Adrenaline is a 1A antiarrhythmic drug. And the patient went in fibrillation, ongoing fibrillation, and he couldn't defibrillate. So I came there. We put our thing on, we put the Lucas on, we put the fast track on, and we went, and we went, and we went for 130 minutes. We put some intralipid in it, of course, but after that, the patient survived, and 2 days later, he came back for a PCI procedure. It was magic. But we know it could work. So, Now we end. We come to 2013, almost at this end. Yeah. This is our method, how we do CPR. We can look for it afterwards. But the main thing is use very, very little adrenaline. Almost nothing. And it is the fact that we don't use more than 4 to 5 milligrams adrenaline. No more. Really. Right. This one, Robertson, I think you know him, showed in the link trial that mechanical CPR is really good stuff. It lasted for a really long time, much too long time, but it worked, and everybody say, okay, it works. And this is the last thing. These are unpublished data, people and colleagues. We will finish it end of December, and then we're going to publish it. So you see, up till now, we have 179 patients. And you see here that, yeah, this is in Dutch, I'm sorry. This is surviving, this is dead, this is a total amount. Asystole, ventricular tachycardia, ventricular fibrillation, pulse electrical activity, and bradycardia. We took 4 and 5 together because there are not many amounts, and then we get this, all right? We put some analysis on it, and we saw a ROSC of 32.69 in 179 patients. Is this significant? Yes, it is significant. It's no bullshit. It's true. It works. Right. Is it this the end? Or is it just the beginning? It's like a song by Adele. Huh? But still, I believe it's just the beginning. I thank you very much.